really lovely to see such enthusiasm in the room, and it's the afternoon, so I'm sure you're all kind of stagnating a bit, so thank you for sticking with us. For anyone who doesn't know, my name is Carrie Llewellyn. I'm a professor of applied behavioural medicine. I'm a psychologist. I'm also head of the Department of Primary Care and Public Health at Brighton and Sussex Medical School. I work across quite a few regional initiatives, the Applied Research Collaboration being one of them, and it's really great to be involved with the HRP as well. And it's really good to see so many of you here today. I'm not going to talk at length. It's just a few things that I want to say before line-up of excellent speakers. So really, underpinning the whole of this conference is the aim of reducing health inequalities, and how, as a healthcare system, we can mitigate or influence the social determinants of health. And by this I mean things like poverty, things like housing, income, employment, all of the things that shape the conditions in which we live. And many of these things are informed by local, regional, national policies. It's worth reminding people about the Chief Medical Officer's Health and Coastal Community Report, which is now 2 years old, but which highlighted the stark regional health disparities and the concentration of pre-existing health conditions and chronic conditions in certain geographies, and Stephen's spoke about this a little bit this morning. Coastal communities have particular health challenges, and there are many reasons for poor health in coastal regions. And these vary across the UK, from the north and the south, but locally you can see, and as Stephen's already said, how our wards of deprivation are often hidden by relative affluence, especially in Brighton and Hove, with the wards of least and most deprivation almost nestling together. Granular data is often limited, and research funding is often concentrated in larger areas. And I think the South East, if you exclude London, has not benefited from the research funding that other areas in England have enjoyed. So inequalities come in many forms, they exist everywhere, and this has far-reaching impact on people's quality of life, the access to adequate diagnosis and treatments, and it affects mortality and patient-related outcomes. A recent illustration of this was shown, you might have seen it in the press, about analysis of hospital and primary care data that demonstrated that being female, being black or Asian, or those living in areas of high deprivation were significantly less likely to be offered heart valve surgery in England. Women as a group also receive fewer and less timely interventions, they receive less pain relief, and are less frequently referred to specialists than men. And it's really nice to hear some of our talks today that will be focusing on this. Women of colour are at particular risk of poor health outcomes, and as we all know, intersectionality often increases these health inequalities. So there's much work really needed to look closely at whether these disparities are as a result of structural or systemic inequities, whether there's genetic inequalities, whether there's differences in patient behaviours or patient preferences. So we've heard from Liz and others today about the importance of high quality data and to be able to quantify health inequity and to identify the gaps. And in addition, this data allows us to see also who's missing from services, which is really, really important, and who is being systemically excluded from services and from research, and who's struggling to access. So who's not seen the data that we might expect to see there, and how does our data regionally compare with other regions? Understanding our regional data is of absolute importance, first step to us proposing solutions. And of course, reducing health disparities is not just about reaching the right people in services and in our research. It's also starting with who's in the room when these conversations are taking place. So I'm going to float a couple of questions for you to mull over during the rest of our afternoon. So, who's in the room today? If we look around, who's here with us? Are the leaders and the doers of research a diverse set of people? Are we representative of people from all walks of life? Are we using our voices appropriately? And are we bringing people to the table who represent those that are seldom heard? Are they in the forums that we'd expect people to be in? And are we really ensuring that what we do is not having any unintended consequences and widening existing health inequalities by not involving the right people at the right time? So I hope you've been pondering the questions that I sent earlier about who have we got here? Have we got all the right people in the room? Is there anyone missing that should be here? Are all the voices being heard that really should be in these kind of spaces when we're making decisions about the direction and the strategy of where we're going? So I think it'd be quite interesting to see whether or not we've hung our heads or whether we think we've done a good job here. I hope Martin doesn't mind me saying that the HRP is doing a mapping exercise. Is that okay?
I was going to say later.
Well, I'll speak in my best interest. So we are doing a mapping exercise of health inequalities research work that's going on. Obviously, health inequalities is a broad church, as you've seen today. It can encompass so many different things. But if anyone thinks that they are doing things that speaks to this theme, then please do get in contact with me, and I will be trying to put together people that are interested or people that are having ongoing work or anyone from this region really. Great.